My name is Cynthia Klein, and I serve as the Project Director for Take Heart. Thank you for joining us today on our webinar. We are going to be covering the CMS final rule that was recently released and its implications for strategic planning as we look to leave behind 2020 and move into 2021. We are again grateful to have with us Dr. Hisham Scally and Dr. Stephen Hines, who will be guiding us through today's discussion. And we are also thankful to have with us Karen Louie, Dr. Steve Katayan, and Sarah Schaub, who will be working with us as panelists today. Before we move forward, just a quick update on Take Heart, if we can move to the next slide. You know, as we communicated last time, we are beginning to prepare to restart Take Heart next year. Most likely, we will start in the second quarter of 2021 and possibly as early as April. You know, I wish we had a crystal ball we could look into for the future. I bet we all do. But in the absence of that, it is the utmost importance to us to stay in close contact with our partner hospital participants so that we can adjust our timing, we can adjust our support as needed, and we will do exactly that. If you do have any feedback that helps inform our restart plans, we would always love to hear from you, and you can reach out to us through the Take Heart email address. Please note that as is feasible to do so, we have asked for our partner hospitals to start thinking about and maybe start working on a couple of activities. So if you are a partner hospital in our first cohort, so you began with us at the beginning of January, we've asked you to complete a data planning exercise to start laying that groundwork for automatic referrals. Partner hospitals that are in our second cohort that have not yet started, we have asked you, and hopefully you've received an email at this point, to complete a readiness assessment to help us really better prepare to be able to support you. In the meantime, we are going to continue to do affinity groups like this on priority topics. We will continue to do topics related to COVID, begin to branch out into some additional topics that are, you know, maybe less COVID specific, but more around cardiac rehab in general. And as always, the Take Heart website continues to be updated with additional links in the Resource Center that, and also resources that are related to COVID-19. I think we'll have a really great discussion today. And with that, I'm going to pass it over to Steve.
All right, thank you very much, Cynthia, and we are excited about today's event, and I think that we've already topped the most attended event so far in the history of Take Heart, and so we're excited about today. We want to emphasize that all these events are designed to help everyone learn, everyone share via the chat, and really we want to feel like every person here feels supported by their peers. This is not a case where you listen to panelists. This is a place where we want to encourage you to interact, not just with the panelists, but with each other using the chat and the polling functions. So Cynthia has already mentioned our speakers for today, Dr. Hisham Scally, as well as Karen Louie, Stephen Katayan, and Sarah Schaub. They're excellent. I've learned a great deal talking with them in preparation for the day, and we're going to get to them very shortly. We do want to encourage you to use the chat function to ask questions, to respond to comments made by others in the chat. And if you can make sure that you pick the option for sending your chat to all participants, that will make sure that it goes to both the panelists and to your peers on the call. So we want to definitely encourage you to use the chat as much as you can, and we pay attention to those comments and follow up on them later. As far as the polling questions are concerned, we have just 3 questions that we're going to introduce you to today in just a second here, and we want to make sure that you have a chance to give us some input. We use this input. The panelists find it helpful in knowing topics that they may want to spend a little bit more time on, and then we're also using it as part of our ongoing planning for Take Heart. So, and we want to remind you to hit the submit button after you respond to each question. So let's move to that now. Our first polling question: what best describes the current status of your hospital's cardiac rehabilitation program? We've been asking this question. We've been trending this over time. So just take a second here and give us a sense for whether all of your on-site activities are canceled, but you're supporting patients other ways, or whether you've got some on-site, or things are moving back to normal, but you've got less than 60% or 60 to 80% or over 60 to 90% or over 90% capacity. So take a second to pick your descriptor that's most accurate, and then remember to hit the submit button when you're completed, and we'll look at those results here in just a few seconds. All right, and those results should come up here. All right, so looks like most of you are in the reasonably normal, but you know, either less than 60% or between 60 and 90% capacity, and that's similar to what we saw a month ago. All right, let's move to the second polling question. And then we're very interested in trying to understand where you're likely to be at as you enter 2021. So if you could just pick the challenge that best describes the biggest one that you're expecting at the start of 2021, whether that's the availability of staff that you'll need for your program, or insufficient capacity to support all of your cardiac rehab patients on site, or if it's convincing patients to use the capacity and the staff that you have to continue or begin on-site cardiac rehab, or if it's successfully transitioning more patients to alternative or hybrid cardiac rehab approaches that don't necessarily require as many on-site visits. So take a second. There may be a couple of those challenges that resonate with you, but try to pick the one that you think will be the largest as you enter 2021, and we'll see the results here in just a second. All right, so this is very interesting and helpful. So the concerns seem to be some related to staffing and on-site capacity, significantly more associated with convincing patients to continue to participate in cardiac rehab. And we've heard from a number that, you know, patients are saying, I'll put this off until after the start of the year, and so it's useful to see that from this group. And then it's also useful to see that, you know, a quarter of you are planning to work on transitioning more patients to alternative and or hybrid models, and several of our panelists have useful insights on that. Moving to our third question, we want to focus some on this with respect to the final rule, and get your sense for your plans for providing virtual cardiac rehab services and billing CMS for those. So what best describes where you're at right now? Are you already billing for virtual cardiac rehab services, or getting ready to do that, but you haven't started yet? Or you'd like to do that, but you're still working through the nuts and bolts of doing that and trying to get all the permissions? Or it may be that you're just focused on your on-site cardiac rehab, and that's not a priority for you. So take a second and pick which of those options best describes what your plans are, and we will take a look at them in just a second here. All right, so a lot of you are planning to bill for virtual services, and you're working through the nuts and bolts of that. Some are not planning on doing this at all, and that's perfectly fine. You understand your patients and your needs better, but that's very helpful for us in planning, and one of the reasons why I think attendance is so high on the event today, since our panelists will be talking about this. All right, excellent. Thanks very much for those responses. I want to turn it over now to Hisham to give us an overview and lead us into the substantive discussion for today.
Thank you, Steve, and Cynthia for the introduction and leading the polling questions. I want to welcome everyone to this very exciting session today with Karen Louie and Dr. Steve Kitayan and Sarah Shao. We're going to go over the recent final rule by CMS, but really this is a point for us to understand and try to go over what we know so far about what has happened over the last year, but also what to expect for the next several months, and really set the limits and the field about what is it we actually know and what is it we're still unclear about and we don't know, and how to be prepared for a few options and scenarios that will happen. And I think what we have learned so far in the last year or so, we were discussing with our panelists earlier, is that, I mean, this year with all the challenges and the constraints we had, one of the positive things that came up of it is our ability to act as a community, to learn from each other, support each other, and collaborate for the sake of everyone. And so, and then another testament to that is that we have over 180 people attending this session today. It's one of the highest numbers we've ever had. And again, it is with everybody getting together and working together and thinking together that we can move forward, advance in this field, but also support each other in this very challenging time. So with that, what we like to share here in this schematic is in this week, CMS came up with the 2021 final rule, and this will create opportunities for hospitals and physicians for the coming months and years. And there are at least two aspects to this with different setups, different rules, and different decisions. And we're very lucky and grateful to Karen Louie, who's set up some time for us to discuss, to explain this to us as a community and to all the cardiac rehab practitioners. She's already had a first opportunity to discuss this as part of an AACDPR webinar, but this is as part of the Take Heart, and this is, again, as we go, we have more questions and certitudes that we're trying to clarify for everyone. Karen, thank you very much for being with us, and I'll leave it up to you to explain to us what you think about how you read this CMS 2021 final rule.
Thank you very much, Hisham. Hello, everybody. Good morning, good afternoon, somewhere probably. And I think I have to laugh as I was hearing you. You know, when November comes, most of us think, what's the big event? And many would say Thanksgiving. For some of us, it's the release of next year's final regs. So there's room for all of us, right? And the word analyst by my name just clearly states that if the rules were clear enough, we wouldn't need an analyst, but they are not. So we all learn together, and I appreciate the questions and the comments from all of you who are dealing with it day to day, because I learn as much about the process and the rules from you as you do from me. So with that, we'll dive in, and I think have a little chance to go maybe a little step farther than I did on Monday when we had just hit, the rules came late this year. They had just hit. We're working through 1,000 pages of each, but there's some basic pieces of information that you really have to have clear before we can talk about our regs and what matters to us, because Medicare, CMS, publishes two sets of regulations every year. One is for physicians, and one is for hospital outpatients. And in every July, they publish what they are proposing, they think, to say in the final. And then we're all given the opportunity to write comments, and we always do. And sometimes those comments are actually addressed in the final with their thought process and their response. It may be a thumbs down, thumbs up, but it's certainly a public forum as the process develops. So we'll drill down on that a bit. Next slide. And the physician fee schedule is not the one we care the most about. Let me put that in your head right now. These are the rules and the payment rates for professional services. So they're for physicians, and the term is qualified health practitioners I think we all know those are nurse practitioners, physician assistants, folks who are eligible to bill Medicare independently using their own CPT codes that are identified as physician and QHP services, like an office visit, like an evaluation and management service, like a physician who interprets a reading on something, like a psychologist can bill for services, like a dietitian, different than what those of us in the hospital setting, clinical staff most often, as we are defined, live with. And so hospitals, we've got to get this straight, hospitals do not bill for telehealth services. And that's a quote repeated multiple times in CMS documents, because hospitals don't have the ability to use telehealth codes. The large number of us here, I believe, are in a hospital outpatient setting, so I apologize to those 2 or 3 of you who are in a physician-owned or setting, but you know who you are because you beat to a different drum. Hospitals are currently able to provide virtual delivery of services, but please don't call it telehealth. Let's call that virtual delivery, because that's what CMS calls it. There are some similarities. Billing physicians have a different form than your hospital billing department uses, and the payment rates are different and calculated differently and quite different. And that's, we won't go any deeper than that's why most of us are now in a hospital outpatient setting. And there are some similarities as well as differences. Fortunately, the regulation that covers cardiac rehabilitation, which many of you helped put into the Social Security Act 12 years ago, does allow a cardiac rehab program to be in a physician office or in a hospital outpatient setting. And fortunately, at that time, somebody had the wisdom to say, there may be other settings, and that can be determined by the secretary, meaning CMS. So that meant we wouldn't have to go up to Congress and say we need another setting, like home, whatever. Same procedure codes are shared, again, different payments, and the same provision is the one we all follow, 410.49, which is the page and a half of the rules that CMS has given us, with a few little differences based on whether it's physician or hospital. So just know the subtleties of differences, but we're going to really focus on the outpatient setting. The physician fee schedule, here's where there's been a lot of confusion, which is why I'm going to hit this hard one more time. The physician fee schedule included cardiac, intensive, and pulmonary in a list of temporary telehealth codes. And those are for physicians and QHPs for professional services. But those codes are not available to hospital outpatient cardiac rehab because, remember, there's no professional component to hospital outpatient rehab. It's one institutional claim. The physician work, the physician medical director, the supervising physician is rolled into that one code that hospitals are allowed to use. So again, that's why I'm going to be a stickler. It's a little bit more than semantics. We're really today, I think, not going to talk about the telehealth codes, which are different. We're going to talk about the cardiac rehab codes and processes that are available to us in a hospital outpatient department. There are 2 issues that I will drill down on, and that is, the first is virtual direct supervision. And CMS did propose in the spring or the summer to allow direct supervision to be virtual. Some of that was the COVID effect. And I offer this as only I wanted to put verbatim the regulation in there so that when you, and if you need to discuss this with your business or billing office, you have the actual reg in your hand. But the next slide will go, let's walk through it with 4 points to be made. And the first is that the physician must be immediately available. We've lived with that from our inception. Immediately available. That does not mean the physician must be in constant audiovisual contact through the entire session. And there was some lack of clarity in the proposed regulations, and actually ACVPR said that that doesn't make sense. You need to clarify that. What you really mean, we think, is they need to be immediately available throughout the entire session, but not immediately watching the screen, because that would be a different level of supervision. So that's the first one. Immediately available, doesn't matter where they are. It must still be directed, be provided by a doctor or a DO. I get this question a lot. NPPs, nurse practitioners, physician assistants, may not supervise cardiac rehab until January of 2024, and that's because of the work a lot here on this call I know, who helped get an effective date for that to be allowed, but that doesn't come till 2024. The third point is this virtual supervision is in effect until the end of the calendar year in which the PHE expires, or until December 31st, 2021. We all hope that's going to be at least not into 2022. So in my mind, I'm kind of thinking at the end of December of 2021. And the fourth point is that immediate availability is met with virtual presence through audio, video, real-time communications, should it be needed, and that does not include audio. So if they're called on, they need to be immediately available in real time by audio video. The second issue that we asked about after proposed and before final was we really would request that cardiac rehab be able to be delivered virtually in a permanent basis, not just on a temporary basis. CMS did confirm that our programs are eligible to participate in the Hospital Without Walls waiver, and that's the waiver that gives us the ability to provide cardiac rehab in the home. But again, these sessions are delivered, and look at my terminology here, using real-time interactive audio and video technology. I didn't say the other word, did I? So let's not call it what it's not. We need to call it what CMS calls it, only for clarity, understanding. Otherwise, it gets very confusing. And this waiver is in effect until the expiration of the PHE. We don't know if it might be extended beyond that or how long the PHE will be in operation, but the virtual delivery, the Hospitals Without Walls, ends when the PHE ends, as it stands now. I'm going to go one step farther, and if you're scratching your head with this, I apologize, but I think you need to hear it once, and you'll hear it again, and it will begin to sink in and make more sense as you talk with your billing office and your hospital administration about taking this step. It's your cardiac rehab's original location and some modifiers and instruction on using those that will determine if your program needs to file an extraordinary circumstances relocation request. Now let that roll off your tongue. In order to do the home equals provider-based department service, if you're on campus or you're in an accepted off-campus, meaning you've been there since longer than 2015 and you're grandfathered, you will remain at that hospital outpatient rate if this request has been filed. You can go ahead and start your home virtual delivery, but within 120 days, you need to just fill out that extraordinary circumstances relocation request. If you're in an off-campus location where you established or moved after 2015, you don't have to do this because that, in effect, determines what the payment rate is. And you're already receiving that physician fee schedule rate that's 40% less than the hospital outpatient rate. So filing for that extraordinary circumstances isn't necessary. Now, I know that's a lot to say, but I think you need to understand that if you're going to sit down with your billing office in the planning. So bear with me. What I've given you here is a big key. This link will take you to 130 pages of instructions. They don't all pertain to us. Sigh of relief, but these are instructions for how to move forward making your outpatient cardiac rehab sessions virtual. There's some coding and billing and modifiers. And if you go straight to Section G, which talks about the hospital outpatient services on or off campus, you'll understand what I mean. Section H has a little bit of relativity for us, a little bit in Section Z and LL. And LL has a nice algorithm which clarifies for you why and what bucket we fit into in virtual delivery. So I encourage you to take a look at that. You know, if you can word search cardiac rehab even. But this will explain for the hospitals without walls. And that link is updated all the time. So in fact, it was just updated on the 8th. So it's current, it's accurate. Medicare Advantage plans, they are required to cover all services that the fee-for-service, the traditional Medicare cover. They have some flexibility in in which modifiers they use or don't use. Remember, each plan processes their own claims that you submit rather than your MAC, your regional Medicare processor doing it. So for that reason, it's unfortunately important to call with those MA plans and verify what their particular processes are for covering the virtual rehab as well as, you know, all the rehab. And private payers is a whole different ball of wax. They review Medicare rules and they choose to either follow or not. It's up to their Medicare review committee, which is usually a group of physicians. Private payers determine which diagnoses they're going to cover, what the payment amount is, what codes you use, how many sessions a patient gets. So you really need to pre-authorize with those private payers. And we don't know yet. You know, we'll learn together. I'll learn from you which private insurers are expanding coverage to virtual cardiac rehab, which already do that, those forward thinkers. And it is advisable to check and just make sure that your information hasn't changed on any specific insurers. The easy part is you probably work with an actual, you know, 2 or 3 top Medicare Advantage plans in your area. So it's not like you're making hundreds of calls all the time. You will come to know which policies cover what. So, and I think that's, in a nutshell, everything I know.
Thank you very much, Karen. That was quite enlightening again. And I really like how you split up 113 pages of regulation and so on into really 2 questions of really where is the cardiac rehab delivered, and so is it out, and we're not going to call it that word, and also how is the supervision done, and that's the other issue that's been clarified by CMS. So we've got quite a few questions on the chat box. I haven't had, I was so focused on what you were saying, so I haven't had a chance to read that, but I think a few of the questions that came were what kind of platforms are you using, and so I see some people mentioning some different vendors, channel, phase 3, and some others using just general platforms such as Zoom or WebEx, and it's really a matter of figuring out and trying, first of all, what are you comfortable with and what works within your system, and checking with your compliance officers in terms of privacy and HIPAA rules and so on. So the vendors offer obviously a little more than what you would do by yourself and more support, but certainly it's something that I think every program is going to have to check in terms of their budget, demand, and constraints, how that works. So we will ask Dr. Kitayan for his opinion about this. You know, what do you think, first of all, about the CMS rules in terms of the opportunities that it creates, and also how we will be able to navigate through COVID with this and maybe even beyond the pandemic. And while you're doing that, we'll see if we can get through some of the questions later on. Thank you for being with us.
Thank you, Hisham, and my thanks to Take Heart overall for inviting me into the session. And Karen, again, wonderful job breaking down chaos into some slides that we can interpret. But I view this as another opportunity. I've said this before, that there's not a better time to be working in the field of cardiac rehabilitation than right now. We have so many forces pushing us in the right direction, and CMS's policies here help us keep going forward, in this case, supporting alternative delivery. Relative to 2021, by no means, I have stopped trying to predict where this COVID issue is going to be in the future. So I'm just relying on the health system's plans, in this case, Henry Ford's plans, that we're really looking towards the fall of next year before we see ourselves potentially coming out from underneath this, because vaccinations will have a little bit better penetration. The disease itself will wax and wane. Those people who contract the disease will be at a slightly higher percentage. So by fall of next year, we think things may stabilize a little bit. So bottom line is, between now and then, much of it is the same of what we're doing now in terms of masks and space and hygiene and all those things that we've learned how to do. And I have to commend everybody that we changed thinking literally on a dime back in March and April of last year. And as Hisham suggested, these are smart. You all are smart people making quick decisions, right decisions to modify things accordingly. So I applaud you for all of that. The only other thing I want to mention in a bit of time that I have are two small points. First off, you have to remember that if the patients aren't coming to rehab, likely is they're not doing exercise on their own at home. So people, and there's been a couple studies that have already started to look at this, people who don't come to cardiac rehab are even more inactive than they were before. So getting patients to rehab by hook or crook, or virtually connecting with them, is very important. Second, and this is just a paper that we've recently had accepted in Mayo Clinic proceedings, and it was a retrospective study, but we looked at 200, almost 300 some patients who had a fitness level measured by a stress test, physician-ordered stress test, prior to COVID hitting in the U.S. And we looked among those people who then contracted COVID, found out that MET level measured during the stress test was related to risk for hospitalization. And around 6 or 7 METs, the curve started to plateau. So below 6 or 7 METs, there was a good relationship between MET level and hospitalization, and then it starts to plateau. Bottom line here, that for every 1 increase in MET, there was a 13% reduction in risk for hospitalization. For those of us in cardiac rehabilitation, that's the take-home point. We're improving people's fitness to improve their overall health. And like other disorders, COVID falls into the bucket that fitness seems to have a relationship to improved health. So, Hisham, let me stop there. And again, thanks for the opportunity, at least in this portion, to present some of my thinking.
Thank you very much, Stephen. Again, very enlightening. And some of the questions we've had, I'll let you think about those as we go. In the meantime, I'm just going to ask Sarah Schaub to, as a practitioner on the field, on the ground, seeing patients and planning for all of this, how I'm sure you, like everyone else in March, April, May, things probably came to a complete halt, and then we had to slowly and progressively get back into full activity. And now, again, gearing up for this quote-unquote third wave of the virus, and then preparing for all of this. So could you please share with us what you think you've learned and how you see the next several weeks and months coming up?
Sure. Thank you so much for having me. I'm humbled to be on a panel with some cardiac rehab, what I would consider Hall of Famers, with their information that they're providing. But from my perspective, we've had to do a lot of pivoting here in 2020 because in March we shut down until the end of May. At that time, we had put in practices in place to spread the patients out, to come up with rules and guidelines to keep patients safe, make them feel safe while they were there. And we were able to restart very successfully. We had kept in touch with patients throughout the shutdown, using email, phone calls, and things like that, kind of waiting until we felt like it was safe. We opened back up successfully, and then we operated at fairly normal levels throughout the summer. Once the fall hit, we were hit pretty hard in our area with COVID, and that has started to really affect our attendance and people's willingness to come to on-site cardiac rehab. With the help of AACDPR and their work on pushing through the virtual, we are now poised to start our hybrid program where we're going to offer some virtual cardiac rehab as an option. And so we have been sort of planning and getting ready for that. And so we are cautiously optimistic about 2021. And I think, like Stephen mentioned, the latter half of 2021 hopefully looks better for the on-site. But we will definitely continue to offer the virtual option and also offer on-site with the safety measures we've put in place to try to continue to deliver our services to everybody who needs it.
Very good. Again, admirable how the different programs have been able to pivot, go from complete functioning to stopping to restarting to supporting patients and each other. So really amazing and admirable. Few questions that came. I don't think we're going to be able to address every single questions here on the panel, but they're extremely informative and to the point. We will try to get an FAQ with answers for all of these, or most of these at least, that will be available on the Take Heart website within a few days, hopefully. A couple that I noticed there. One, I think, as I mentioned, you should check with your compliance officers and with the program and your staff on what platform works. Certainly, an important stakeholder, as Greg Merritt mentioned, is the patient. So you probably will need to address and figure out which of these platforms are more patient friendly, and depending on the class of patients you have and how much support you can provide to them. The other thing also, one of the questions, and maybe Karen or Stephen, you could help us with this. One of the questions was if we're doing this virtually delivered cardiac rehab sessions, and Karen, please notice that I didn't use the word you said not to. Is the payment inferior with using this virtually delivered cardiac rehab session during the PHE?
No, it's not. It's the same because CMS considers it a session like just as delivered at the hospital in a provider-based department. So the payment is the same.
Excellent.
Good question.
So, very good. So I think Karen was able to clarify that and precise. I'm just going to repeat it to answer everyone there. So that these virtually delivered cardiac rehab sessions during the PHE are reimbursed at the same rate as an in-person visit. And another question
Let me just add one thing to that, which was a similar question. Either code 93798 if you're doing real-time audiovisual, or 93797. Either code works. It's just depending on whether the patient's wearing an ECG monitor or not. So both codes equally reimbursed the same with a copayment, just because it's just like a hospital session. So the copayment amount is the same.
Excellent. Yes, and so someone else was asking, are we using wearables for this remote delivered cardiac rehab sessions, and I'm sure there is a great variety there into who's using what and what kind of monitor you're using. But certainly the billing code will be different based on whether you're using the telemetry monitoring or not. And I think with that, this is again predicated on the fact that how long is the PHE going to last? When are we going to have the vaccines? When are we going to have more room for patients? But really, it goes along with, we were thinking about this with the panelists and the team. We were trying to think about this along two major axes. One, which is about demand. And so, you know, how many patients are we getting? Are these patients with the same, as you've seen over the last several months, there's been a significant decline in the number of patients being admitted and hospitalized with myocardial infarctions and angina and other cardiac procedures, whether they're stent CABG or valve related. And so whether that will translate into fewer patients, or actually because of COVID and because of the backlog, we will be seeing a lot more patients in the next few weeks and the next few months in terms of the patients eligible for cardiac rehab. So that's going to fluctuate, obviously. And then our capacity in every rehab center is also going to fluctuate based on either the space constraints mandated by the states or regulatory authorities, or the hospital policies. You know, a lot of the places are operating at 50 to 60% of their prior capacity, but also based on the staff who's available to deliver cardiac rehab. So between these two problems, between the demand, so how many patients are eligible are coming to rehab, and how much can we actually accommodate for in-person visits, that's going to vary from state to state, from center to center, and we will need to think about this, about our staff that might get either infected or in contact with patients with COVID, or furloughed or deployed in other places, in other positions within the hospital. And obviously, as Stephen said, I don't think we can make any significant predictions in that regard. Stephen, what do you think about this way of looking at it?
So I'm with you 100%. Everything you described is fine. I'd also like to suggest that I have viewed this whole COVID scenario as an opportunity, and we've been in the virtual business of delivering remote cardiac rehabilitation since 2016, and we've learned an enormous amount of information as we move forward. This is where cardiac rehabilitation is heading. I encourage everybody to get on board over the next year. Again, CMS has laid us a nice platform for us to do this. I would make the argument that your health system is more ready now to help you do this than ever before. They've figured out an awful lot of the billing issues, the nuances, the behind-the-scene issues, the technology issues to make it happen. The patients have adapted. We are currently using a one-to-one platform routed through our EMR, Epic, but January of next year, we're going to go to a WebEx-based platform that will allow us to do 6 patients virtually, synchronous, real-time with audiovisual communication. It's all doable. But again, this is part of all the new learnings that will make a lot of us in cardiac rehabilitation hesitant. It's new information, it's new terminology. So again, talk to other people that are doing this. Rely on your virtual care departments to help you get started. But this is the way we're going. Enrollment is low nationally. We have to keep our eye on the ball that despite all of this, we've got to improve enrollment in the U.S. and this alternate programming such as hybrid cardiac rehabilitation. It was one option. It doesn't take us away from doing facility-based. That's still our primary approach, but we have to think about other ways to do this.
Excellent. Absolutely, Stephen. I think, as you said, we have to keep our eye on the ball, and the name of the game is get the patients to do cardiac rehab. We're not obviously getting nearly enough patients enrolled in our programs, and that's the CMS, the Million Hearts, and the Take Heart objective is really to get more patients enrolled in cardiac rehab, and this is one of the ways of expanding that offer, and now really with reimbursements being clarified by CMS during the pandemic, one way to get that jump started and offering that as an additional possibility. Sarah, is that how you see it on the ground yourself?
Yeah, I'm definitely in agreement. We are seeing a lot lower enrollment for the in-person. We are seeing a lot of patients that just have fear about leaving their homes. But on the positive side, we have a ton of interest in the virtual rehab. So my best advice for, I have a lot of people are chiming in with questions about it. For me, I wish I wouldn't have waited to get all the right people at the table. I had to end up getting IT involved, compliance, legal, higher level administration in order to, I had what AACVPR had, the groundwork they had laid to kind of show what it was, but this was also new. Everybody really wanted to take a look at it and investigate it themselves before they told me we can move forward. And so if I would have started that process a little earlier, I think I could have jumped in sooner, but the pieces have kind of fallen together, and the staff is on board, and our hospital has a platform they use already called Amwell. They were already doing physician visits using this platform, and we had somebody from IT come in and just sort of tweak it a little bit for our purposes. And so I think that I'm optimistic that this is going to be a good way for us to go. And like Stephen said, I don't think it's going anywhere. So we'll try to keep pushing through.
Absolutely. And certainly, again, kudos to you for getting this through during a difficult time. And I'm just going to use that as a shameless plug for the Take Heart initiative. This is what we aim to do actually in providing that roadmap of how to get there in terms of increasing automatic referral and the care coordinator and liaison to increase your referral and your enrollment in cardiac rehab. Where we certainly have a module about the hybrid delivery of cardiac rehab. So it's really the whole system and the whole enterprise that needs to think globally about how to increase how many patients, eligible patients, we get into our cardiac rehab programs. So again, in terms of the contingencies, we were talking about the capacity. Here we're talking about the demand. So really, as you guys mentioned, we have fewer patients, and so the efforts about recruitment, reassuring patients about safety, maintaining those safety protocols and those physical distancing, face masking, and hygiene and hand cleaning as frequent and as available as possible. And then the vaccine is another tool in our box now that we can use, and we should be discussing about that with our eligible patients. I think one of the questions that I saw quickly scrolling was Sarah, how can you determine what level of exercise, what intensity of exercise would you be able to prescribe when you don't have the usual monitoring that you have for patient insight? I know Stephen has been doing this since 2016, but I also want to get your opinion and Ben Stevens about that. How do we use this non-monitored setups to do an individual treatment prescription?
Well, yeah, we are still new to this. I think one of the things that we're trying to do is still have the patients come for a one-time in-person appointment. And that way we can actually get a better assessment on them, do some type of functional test so we know what their limitations are, do some education on taking their own pulse or making sure they have that equipment and giving them information like where they could get it, like a pulse oximeter or something like that, so they could use that at home. We aren't doing any, we won't be billing for continuous ECG monitoring. We don't have the capability to do that, so ours will be non-monitored sessions. And then we're going to just do pulse checks and utilize our rating of perceived exertion frequently throughout the sessions. And I think that we'll work on trying to prescribe individualized exercise. Patients may not, they'll only be doing a small amount of exercise probably with us in the session, but then we'll be trying to instruct them on some more exercise to do outside of when we're on the virtual session together. So there will be an element of exercise, but certainly also education piece, weight training, stretching, and things like that.
Thank you. Stephen, what's your long time experience in the field with this?
Well, much of what Sarah was said is correct. I would just emphasize that this isn't all or none, that it should be a hybrid model, that you want to have them come in once a week or once every 3 weeks so you can see them in person. And we do use a chest strap wristwatch connection for the people to get their heart rate. We give them the device for them to keep. It's relatively inexpensive. We give them the device so we can get their heart rate. And whether you go 20 or 30 above standing resting heart rate, or you go RPE, all of those are acceptable ways to guide the people in terms of their intensity.
Very nice. Yeah, so I mean, it really speaks to the spectrum there of what you can do. As you said, this is all all or nothing. You can use different materials, different range of how you allow people to do, and the RPE is probably one of the best tools that we educate patients to use when they're not in our in-person during an in-person rehab session. We ask them to exercise on their own. We usually will ask them to base that on their RPE. So this is a really important tool to use. So these are some of the resources that we have. I think this will be available to everyone. We had nearly 200 or over 200 people throughout this session. Karen, any final words on your end from a regulatory perspective and on the CMS final rule?
Yeah, as we've said, it's an evolving, there are questions that I don't have the answer to, and some good questions on the chat, like where does the staff person have to be? I'm not real clear on that yet. I've seen different things. But some of the coding and PO and PN and the modifier use, that's right in the link to this final rule, questions like on that, like location. So those are in this document as cited. And the other comment, I guess, is, we know that during the PHE, CMS has waived the HIPAA compliant need, and so Zoom works, many platforms work. But and Stephen, chime in if you want. I would, you're going to work closely with your IT and compliance department on that. And let's hope that this does have some traction and we can show CMS that this is a safe service, because they're going to need that, because some of the comments in the final were, this is only temporary because we're not sure if it's safe. So we want to be sure we're collecting the right data to answer that question. But maybe setting yourself up with a HIPAA compliant kind of platform going forward. So and some compliance departments probably won't even let you do, escape that, even though CMS has relaxed that rule. So just those are some of my thoughts.
Thank you, Karen. Steve, would you like to comment? Just one question for you. As we said, this CMS only allows this a virtually delivered cardiac rehab session for the duration of the PHE. And some people might think, well, if it's going to be temporary, why invest the time and the effort in doing that? And, my perspective is that these are all patients that we can grab and enroll and help and improve their health right away with this method. Once the PHE ends, and we look forward to that public health emergency to end for all of us, these patients are already captured in our cardiac rehab environment, and we can then transition them to an in-person program. Do you think that's the right way to look at it?
Was that for me?
Yes, for you or Sarah, because the worry is that, well, this is temporary, so let's not bother with it.
I would agree with you. This is the time that we make these adjustments. We're moving in that direction, and CMS will see how well it's being utilized. Is it taken up? How many charges do they have coming in? This will add further support for the utility of reinforcing what we want to do going forward. So I'm with you 100% in terms of that approach to get it out there now, get the model out there now, pull patients in, and build it that we can use it going forward.
Thank you. Excellent. Sarah, any other final words?
I would just say, I'm excited that I was able to gather some support here at the hospital and get the right people to the table so that I could move forward with this planning and that we're going to be able to provide this service. We've seen too many times people are just, they're at home and they're not doing anything. I think either Stephen or Karen had mentioned that the pandemic has not only, kept people at home, but it kept the people at home and sedentary. And so, we have an opportunity here to intervene and try to continue to provide those services. So I recommend working really hard to try to get all those people to the table, your billing, revenue, compliance, IT, and pick their brains, see what they can do to help you. Because once I opened that can of worms, I had a lot more support than I thought I would.
Thank you very much. And I want to thank everyone on this call for participating, for asking the questions and listening, and especially our panelists, Sarah Schaub, Karen Louie, and Stephen Kitayan, for your insights and experience and your encouragements and supports of Take Heart and trying to do the best we can for our patients. And we're just wrapping up. We're at the top of the hour. Our next call will be in the second half of January next year, and we're still deciding on the topic. If you have any suggestions, you can please email them to us, and we'll study them. Otherwise, the Take Heart platform is there available for discussion and collaborations. We will have these slides, the slide deck available there as well. And please, on your logging out, please take a minute or so to complete the feedback questions. Those are extremely useful to us and help us assess how the sessions went, but also determining what to do better for our next session. And with that, I want to thank everyone and hope to see you next time.